Visible?
Yeah, very well.
All right, so I'll be discussing mastering chopping techniques. I have no financial disclosure. Now, why do we need to move on from the traditional divide and conquer to the stop and chop or the direct chop techniques? They essentially help to finish the nuclear emulsification with lower energy, which translates to clearer corneas and lower inflammation. Also, the stress on the zonules in cases such as hard cataracts or zonulopathies is much less. Now, when moving on from the divide and conquer to the direct chop, one should first master the stop and chop technique. I believe Dr. Faisal will be discussing the formation of a trench in greater detail, but essentially it should be well centered in order to divide the nucleus into two heminuclei. Now, the difference between making a trench and doing a direct chop is that lower vacuum settings are required by making a trench because you do not need an occlusion or a hold for the nucleus. So while splitting the nucleus, both the instruments, be it either a PHACO probe and a Sinskey or two Sinskys, are moved simultaneously in the opposite direction. But more important than the direction of movement is the positioning of the instruments. Now, if the instruments are more superficial in the depth of the trench, the forces will act as such that it will just splay the anterior aspect of the nucleus while the posterior plate will still remain intact. So one needs to have a correct positioning within the depth of the trench such that the forces are transmitted posteriorly, which results in a proper propagation of the crack, resulting in two heminuclei. So we'll begin with the stop and chop technique. This is against cataract. One begins with aspirating any loose epinucleus for proper visibility in the subsequent steps. Now, this is one of the most important steps. It is important to widen the trench, especially in denser cataracts, before deepening it, as it gives enough space for maneuvering of the phaco tip and the sleeve. One then rotates it 180 degrees in order to complete the subincisional trench. This is especially important for beginners. If you are more comfortable later, the entire trench can be done in one go. The instruments are then placed, as I had alluded to earlier, and the crack is propagated. Now you can see that the posterior plate is still intact, so one rotates the nucleus by 180 degrees and then continues to complete the crack. Following this, the heminuclei are then cracked. This is done by occluding the phaco tip fully into the wall of the trench. With Sinskey, or in harder cases, the chopper is then introduced either next to or just underneath the Rhexis margin and then is moved towards the phaco probe to complete the crack. Similar principles regarding the trench in moderate or softer cataracts. In these cataracts, one can use the retroflex exaggeration as a point in order to judge the depth of the trench. Additionally, you can use a higher magnification to see the orientation of the lens fibers, which are parallel more superficially and then go on to be perpendicular at the deeper levels. You can see that the trench here has been completed. Now, I'd like you to note here that the placement of the probe and the chopper is more superficial. So as I had alluded to earlier, you can see that there is just an anterior separation in a soft cataract, which is just splaying the anterior nucleus, but the posterior plate was left intact. In a moderate cataract, however, this much of energy would be sufficient to cause a nuclear fractus. However, in deeper cataracts, it is important to have a deeper placement of the instruments. If it is still inadequate, it is advisable to go ahead and widen and deepen the trench again and then repeat the separation maneuver. Now, when we move on to direct chops, there are two conventional techniques that have been described. In the horizontal chop, you impale the nucleus beyond the Rhexis margin at the equator and move towards the direction of the phaco probe in the horizontal meridian. In a vertical chop, however, you impale the center core of the nucleus just in front of the phaco tip and move in the opposite direction of the phaco tip in the vertical orientation. So this is a case of a small Rhexis which has been made in an intumescent cataract to prevent a capsular runoff. It is important to make sure that the occlusion is full before attempting a direct chop. Additionally, the energy parameters should be optimized, and you should make sure you have adequate energy to hold and eat up the nucleus. If the energy is too little, one would inadvertently just push the nucleus forward, which would cause a stress on the zonules. It is also important to make sure that one does not nick the anterior lens capsule inadvertently, so it is advisable to stain the capsule with trifon blue. You can see that the chopper is impaled just beyond the margin of the Rhexis and is then moved towards the phaco tip to complete the crack. Also, multiple small quadrants or segments can be made in this, as it is a relatively smaller Rhexis, and you will have subsequent ease in removing the smaller nuclear fragments. Now, this is a case of a runoff Rhexis in a hard cataract, as we were discussing earlier as to whether we should convert or continue with the procedure. Now, one of the important caveats to remember is that the maneuvering should be in a direction opposite to that of the runoff. So all the instrumentation and the forces are not near to the area of runoff. So one can sit either superiorly or temporally depending on where the runoff has happened. A vertical chop would not be advisable in such a case because it would cause an unnecessary posterior strain in an already compromised capsule. So once the occlusion is done, you can see that we're pulling the nucleus forward, going all the way to the equator, impaling it, moving it towards the phaco probe and propagating the crack. So initially the movement is towards the phaco probe, but once the initial crack is made, both the instruments are moved laterally away from each other to make the crack bigger. Now, one of the procedures that is preferable in very hard cataracts could be a small groove that is made, which is then followed by a subsequent direct chop. Now, this groove is similar to constructing a trench, but it's shorter as compared to the trench and does not encompass the entire length of the nucleus. The advantage of this would be that you would have a deeper hold in a deeper occlusion, which is closer to the posterior medullary blade. And once a crack is formed, it will propagate almost all the way through and help to achieve a good separation. The other advantage would be that it helps to debulk the nucleus, which gives you more space for the subsequent maneuvering and the instrumentation. If the crack is not gone all the way, you again take the nucleus by 180 degrees and make sure it's complete. And a multi-level chopping, as can be seen now, can be done, wherein the phaco probe is used to hold the nucleus steady, and the second instrument is introduced and then reintroduced again at a deeper level in order to complete the crack. Now, one of the most important caveats that surgeons need to remember is that you have to make sure that the pieces are completely free from adhesions before attempting removal. In these leathery cataracts, sometimes the plate is difficult to crack, but it is not advisable to start fishing out for the pieces before complete separation is achieved because it can result in zonular compromise. Now, in soft cataracts, for the beginner surgeons especially, one could do a hydrodelineation as it gives you a beautiful golden ring. The nucleus here is a very precious commodity, so one should use that ideally for a chop. A lot of times what will happen is that the surgeon just eats away at the nucleus and what is left behind is just an uncracked bole, which is very difficult to remove. So here, once you've gotten a center nucleus, you don't even need to use high energy settings, just a good enough vacuum to hold the nucleus steady by propagating the chop. The other advantage of having this central nuclear core is that it can always be flipped out and subsequently removed. Also, the epinucleus will give a cushion to the posterior capsule while the maneuvers are done for beginner surgeons. So once this nucleus has been removed, the epinucleus can then be removed in toto from the capsular fornices. So I'd just like to conclude by saying that you should choose your method based on the case, the hardness of the nucleus, and obviously the comfort of the surgeon. It's not wrong to switch between techniques based on how the surgeon prefers. The groove is a useful technique for harder cataracts prior to doing a direct chop, and hydrodelineation in softer cataracts could give you a slight nuclear central nucleus, which would help to subsequently chop it and remove the fragments. Thank you.
Thank you, Gitansha. Very comprehensive presentation, covered almost all aspects. Comments?
Can I comment?
Yeah, please go ahead.
I think, I think Gitansha has proved that genes cannot go wrong. Her lovely presentation, Gitansha, and you have covered each and every aspect of nuclear emulsification. The only thing is, in direct chop, what I would suggest is you have to go vertically down. Okay, if you're going to do a vertical chop, I do vertical chop only, and I use my sharp chopper, which is about 1.75 millimeter. But these cataracts are very, very thick as well, about 5 millimeters or so, or even more than that. So you go vertically down as if you are going into the anterior vitreous. I do bevel down PHACO if I'm using a straight tip, or if I'm using a Kelman, I go bevel sideways if I'm using a Kelman. But basically what is important is to make sure that your chopper is right in front of the PHACO tip there, okay, and not near the side port. So as soon as you create a vacuum seal in a peristaltic machine, you will hear that sound that you have gone to the preset vacuum, then you chop. Chop straight away right in front of the Rhexis margin. Keep the chopper straight on the straight, directed directly towards the optic nerve. Don't tilt the chopper this way, that way, and make sure that your posterior nuclear plate is completely separated before you go to the other side. And then you chop into multiple halves, and make sure before you bring the nucleus up, make sure that the posterior nuclear plate is completely separated and you see the posterior capsule through and through. Otherwise, you'll have a white cornea the next day. So these are, I think, important parameters. Always use very high vacuum. The vacuum is directly proportional to the holdability of the nucleus. And if you want to do that trenching, use low vacuum, more power. In chopping, high vacuum, less power. I can go in for the pulse or the micro pulse or the hyper pulse, which is there in the white star.
Good points, Mohan. Faisal, how are you placed? I mean, will you be able to run it on VLC? I mean, come to you.
Yes, sir. Now it will play, sir.
Okay, we'll look at your videos after this. Mohan brought up a very important point about, vertical chop and horizontal chop, and about his chopper. Would you use different kind of choppers depending on the type of chopping you're doing, whether it's vertical or horizontal?
Yeah, I'm sorry.
Sorry, sir. Go ahead.
No,
horizontal chopper, don't use a sharp chopper.
Yeah.
In horizontal chopping, you need cortical cushion, okay? Unless you can do it up to grade 3, grade 4, because the cortical cushion is there. Use a blunt chopper in horizontal chopping. Gitansha, what's your take on that?
I'm not a vertical chop surgeon. I prefer the horizontal chop. So the difference would be that a vertical chopper would have a sharper tip. A horizontal chopper would not have a sharp tip because you're going beyond the anterior lens capsule and engaging all the way to the equator, but the edge of the chopper would be sharper. I prefer a horizontal chop in all my cases.
Yes, Partha.
Excellent presentation, Gitansha. Very nice takes on so many important points.
Thank you.
Just two things that if I would like to bring up. One is about the very hard cataracts, in which, just as Mohan said, that the separation is very important of the posterior plate. But there will be instances where the posterior plate will not separate. And it's a bulky nucleus, you cannot stretch it over more. And you have not taken out that first pie, which gives you space to separate the next pies. So at that point, what small technique that I use is, I had described it long ago, it's chop and harvest. Just picking one pie up, and then it's still attached to the posterior plate, and then manually severing it with a sharp chopper. That little sharp chopper edge just cuts it out. And then once that first pie is out of the way, then you have more space in the capsular bag, and then rotate, and then you can separate the next few pieces. So that was one small point. The other is of the soft cataract. The soft cataracts are the most difficult to do a direct chop. So because it eats away and you're right into the periphery before you have chopped. But here is the importance of very, very low settings of vacuum and power and going as deep as possible. And here, the horizontal chop technique is what is very important. So from the periphery, if you have gone into the center and then divide it manually, separate it manually, then it usually separates. But it demands a lot of practice and a lot of cases need to be done before you can actually direct chop a soft cataract.
Very important points, Partha. I mean, especially your take on that, removing that first fragment, one fragment is extremely important. Having said that, maybe in a very hard cataract where the capsular bag is fragile, I do that, but otherwise, I like to chop all my pieces inside the bag and then take them out one by one out. I think that gives me much more control, and then the surgery also happens in a more posterior plane. And as far as soft cataracts are concerned, I think it's not even necessary to go on to PHACO 3. You don't use any power at all, and just with in PHACO 2 itself, you can get a reasonable hold and create the first crack and then proceed with it. If there's no formed nucleus, obviously a PHACO flip would be a much better way. So you can just collapse the entire nucleus out, and then, so it's not mandatory that you try a chop in every case. Any inputs?
One other thing is,
Yeah. No.
of course, Gitansha was extremely good, very practical and relevant. The vertical chop probably has role only in two situations. If it's a hypomature Morganian cataract, maybe when there's no epinucleus cushion, then a vertical chop would help better. And probably again, if it's a small pupil and you have not used pupil dilators, so it is safer to do a vertical chop. Otherwise, I think a horizontal chop will take you through all situations.
Yes,
I will not agree with that, Chitra.
One will fight it out later.
What did you say?
No, he says he won't agree with you. Well, we can settle it. I mean, Arup.
Behind the court. Anyway, it's a very lovely presentation, Gitansha, really nice.
Thank you.
There are a few points that I wanted to make. Number one is, you don't have to be debating between vertical and horizontal chopping. It's a diagonal chopping, oblique chopping. So I take Monadin's chopper. It is actually, I make it 2 millimeters. I go at the Rhexis margin and then combine, so that, so the separation movement, both the instruments tip, they approximate each other in the vertical plane, and then there's a lateral separation. So this is something which has given me very, very good results, number one. Number two, I very often see when I see the videos that the surgeons like to physically separate their hands, when they chop. That should not be done, that results in unnecessary stress to the intraocular structures. So you just need to stabilize the nucleus with a PHACO tip on the right hand or left hand, whichever is the dominant hand, and the chopper, you just rotate it. If you rotate the chopper, you'll see the chopper tip will make an outward movement, and that is more than enough. You really don't have to literally separate both the instruments too much. At all. It is just a rotational movement that comes from the interphalangeal joints. The third point is, if you're using torsional, when I'm chopping a very hard cataract, I will put off the torsional, I'll use longitudinal, chop the nucleus into multiple pieces, and then come back to torsional, which gives fantastic chamber stability.
I think I completely agree with you. As far as chopping is concerned, I switch off torsional regularly. My settings are such that it is a burst of PHACO that I use to get a good hold onto the nucleus and then chop and then go on to the front removal. And the other point is, the initial chop that you take, I think it's good idea to go sub-incisionally as close to the Rhexis margin as possible, so that when you do a horizontal chop, there is enough amount of nucleus material that is there between your PHACO probe and your chopper. And as Arup said, most of the movement happens on the chopper, and your PHACO tip essentially stays stationary.
So another point which we frequently miss out is when I say the surgeons in the YouTube, is when you have started chopping and then you see that a crack line has developed on the periphery, but it's not coming to the center. You do a little bit of sculpting, deeper sculpting, so that subsequently it is easier for the chop line to overcome the resistance of the plate, and come centrally. And as Dr. Ramamurthy mentioned, it comes to the sub-incisional area, then the game is over. It's a very easy case.
Or you can go deeper as well.
That's what I mentioned, go deeper.
And go deeper as well.
Yes, Shreesh.
Yeah, I use a direct chopping technique. It can be either horizontal or vertical, and sometimes combined horizontal and vertical chopping technique I use. The PHACO tip, there's a few tips to the beginners maybe, like this thing, PHACO sleeve, it has to be retracted from the tip for about 1.5 millimeters so that you can have a good purchase of the nucleus. So you can impale the tip in the nucleus so that you will get a good hold on the nucleus. My second instrument, that is a chopper, I use a 2 millimeter chopper, the long chopper for hard nucleus, and for moderate or soft cataracts, I use a 1 millimeter chopper.